I'm Dr. Louis Mazzarelli, Director of Molecular Imaging at Lawrence Memorial and Westerly Hospitals. This is the prostate-specific membrane antigen case series, and this is an integrated approach to PSMA PET with multiparametric MRI of the prostate. Let's get into this. So the objectives. Let's recognize how prostate MRI and PSMA PET provide complementary information in local and systemic disease assessment. Compare the conspicuity of lesions across MRI and PSMA PET. We're going to integrate findings into a clear management-oriented report that addresses both anatomy and biology. We'll appreciate the heterogeneity, intra and intertumoral heterogeneity, and its impact on imaging and clinical decision-making. Let's do a primer for reading prostate MRI for the non-MRI reader. Key sequences in reading MRI of the prostate are as follows. T2 weighted imaging, axial, sagittal, and coronal planes. That allows us to define zonal anatomy, the capsule, seminal vesicles. Diffusion weighted imaging, that looks at the biology of lesion. We look for lesions that have abnormal restricted diffusion or abnormal Brownian motion, and those are our suspicious lesions. Dynamic contrast, looking for early focal enhancement, which supports suspicion on T2 and diffusion weighted imaging. So simplified approach to prostate MRI reading is as follows. Step 1, identify the lesion location. Is it in the peripheral zone or the transitional zone? Step 2, look for low T2 signal or dark focus with matching restricted diffusion. Step 3, correlate with PSMA PET uptake for concordance or discordance. Common targets, we look for the prostate bed, we look for the seminal vesicle, and then we look for evidence of extracapsular extension. So let's look at an example. Coronal T2 weighted image demonstrates T2 hypointense signal within the right peripheral zone. We see a sagittal B1400 diffusion image demonstrating bright signal, an axial diffusion weighted B2000 image demonstrating very bright signal, and another axial T2 image demonstrating that T2 hypointense focus, and we beautifully see the correlating abnormal focus on prostate PSMA. Let's talk about local staging of PSMA. The goal is to detect and localize primary tumor and other lesions within the prostate. We want to qualitate and quantitate the degree and homogeneity of expression to predict response to therapy. Absent or low target expression limits the ability of PSMA radiotracers to evaluate disease burden and similarly response to PSMA-targeted therapies. Similarly, lesions with low PSMA expression and high glycolytic activity portend worse prognosis and shorter overall survival. Lesion analysis may allow evaluation of intratumoral and intertumoral heterogeneity with higher SUV and maximal dimension predictors of higher grade group. Let's talk about lesion size on PET and MRI. The general principles are as follows. MRI and CT remains the gold standard for precise anatomical sizing. The PET resolution is limited comparatively, and avid uptake often appears larger than the true lesion due to partial volume effect. So understand that when we're looking and measuring prostate MRI lesions, we want to exclude that uptake in the halo, which can exaggerate margins. PET-CT should not replace MRI for surgical or radiation planning dimensions. The best approach is to describe the PET avidity, the SUV, the distribution, the uptake volume, and then cross-check with the MRI for CT for size. Teaching pearl here is as follows. Lesion size on PET is approximate. Metabolic volume may reflect biology, but anatomic size is best from MRI and CT. So a clear example here, we see a halo of uptake. We see intense uptake within the prostate, but the true size of the lesion is identified on both diffusion weighted imaging, dynamic contrast imaging, 2.2 on PET if we were to look at the halo and the lesion, 1.5 true anatomic dimension. It's a case of Gleason 4+3 disease in the central zone. This is a 73-year-old with rising PSA, current PSA of 6.1 nanograms per cc. Coronal T2 weighted images on the MRI of the prostate demonstrate a T2 hypointense lesion within the right peripheral zone. That same lesion is discriminated on the axial T2 weighted imaging. Sagittal and axial B1400 and B2000 images demonstrate abnormal restricted diffusion. PET-CT demonstrates an abnormal focus of intense uptake within the right peripheral zone and a lesser focus of uptake within the left peripheral zone. We look at the biopsy results in this case, and there's some discordance. On the biopsy results, we see that there was disease identified within the left prostate that was Gleason 4+3, grade group 3, and the left lateral base, similarly grade group 2. But interesting, no focus of abnormal uptake that was identified in the right prostate. We look again at the prostate PSMA. We identify lesion B, which is in the right peripheral zone that correlates with that focus of abnormal uptake on the prostate MRI. That was about 1.4 centimeters on the MRI. And then we see the second focus of uptake in the left peripheral zone, more anteriorly, and that correlates with this lesser region of uptake within the left peripheral zone. So very interestingly, there are two lesions. The second lesion is much less PSMA avid and is MRI occult. So it's a case of tumoral heterogeneity. Tumoral heterogeneity, let's discuss it. Both MRI and molecular imaging may demonstrate intertumoral and intratumoral heterogeneity of prostate cancer within and outside of a gland. PSMA PET may demonstrate lesions not identified in NPMRI, just as NPMRI may identify lesions not visualized by PSMA, although the greatest yield in terms of evaluation is a combination of PSMA PET and NPMRI to detect clinically significant prostate cancer. Intertumoral heterogeneity may reflect differing tumoral histological grade groups. Higher grade tumors may demonstrate intratumoral heterogeneity reflective of inhomogeneous uptake on PET, as may be seen with inhomogeneous ADC maps and inhomogeneous enhancement on DCE. As prostate cancer dedifferentiates, PSMA uptake may similarly change. The primary tumor metastases may similarly demonstrate different PSMA expression. Let's look at a different case. Staging of prostate cancer. This 76-year-old PSA 8.35, no previous prostate biopsy. NPMRI demonstrates a PIRADS 5 lesion, left peripheral zone, the apex. Biopsy, grade group 2, PIRADS 4 on the left, lateral peripheral zone, base. So the PSMA PET demonstrates two concordant neoplastic lesions correlating with the NPMRI, which was otherwise negative. And these lesions are different. They demonstrate intertumoral and intratumoral heterogeneity. The left peripheral zone lesion is larger with greater SUV uptake, and it abuts the prostatic urethra. The left peripheral zone base lesion is smaller, and that lesion demonstrates inhomogeneous uptake, reflecting intratumoral heterogeneity. Let's look at this lesion again and correlate that with the MRI. So let's look at the left peripheral zone apex lesion. So PSMA PET demonstrates axial fused marked metabolic uptake correlating with that area of uptake that we saw. T2 axial images demonstrates T2 axial hypointense signal, clear abnormal restricted diffusion on B1400. The ADC map demonstrates marked abnormal ADC hypointense signal correlating with that same area of abnormal metabolic uptake. And again, here's the coronal fused imaging. And what we're doing here is we're comparing the area of uptake at the left apex compared to that more inhomogeneous uptake near the left base. So this was, again, lesion 1, marked abnormal restricted diffusion and enhancement, abutting the external prostatic urethra, high risk for local recurrence with prostatectomy. This was a Gleason score of 3+4, grade group 2, 10% Gleason grade 4. Now let's look at the other lesion at the left peripheral zone base. So PSMA PET demonstrates inhomogeneous metabolic uptake. Again, more peripherally, marked uptake, more medially, lesser uptake. Let's look at the ADC map, the DCE, and the sagittal B1400 DWI. When we look at the ADC map, we see that this lesion has inhomogeneous ADC uptake, and similarly, it has an inhomogeneous pattern of enhancement on DCE. Sagittal B1400 correlates that area of abnormal uptake on DWI, which is inhomogeneous. So this is an inhomogeneous area of uptake on PSMA PET that suggests intratumoral heterogeneity reflected both by the lesion's inhomogeneous ADC map and rim irregular enhancement, and also the location. The location of the tumor at the central zone portends a predictor of higher grade histology. And this was in fact Gleason grade group 4, this was in fact Gleason 4+3, grade group 3 with 30% Gleason pattern 4. Let's look at another case. Staging of prostate cancer. This was an 81-year-old male with a rising PSA in 2022, 13, 2021, 10.8, 2020, 9.8. Negative trust biopsy in June of 2021. MPMRI PET in November of 2021 demonstrated a PIRADS 5 lesion within the left mid-transitional zone. Biopsy at that time, Gleason 3+4, 35% of the core. Region of interest was the left mid-transitional zone. And also the patient had a biopsy of Gleason 3+3 within the right lateral base. So PSMA PET was ordered to plan definitive therapy. So when we do the PSMA PET, we see something very interesting. There's not one lesion, there's not two lesions, but we see 4 discrete lesions with PSMA PET. And these lesions each have different metabolic uptake. Lesion 1, 27.8, lesion 2, 21.4, lesion 3, 12.9, lesion 4, 4.5. Look at those 4 lesions. Lesion 1, lesion 2, lesion 3, and lesion 4. So in fact, PSMA PET doesn't show 1 lesion or 2 lesions, it shows 4 lesions. Okay, so let's look at this patient's prostate MRI again, retrospectively, knowing what we saw on the prostate PSMA PET. So looking through the ADC images, now looking carefully, we see correlates with all of those 4 lesions, areas of abnormal ADC hypointense signal, correlating with the areas of PSMA metabolic uptake that we identified on the PET-CT scan. So here's an example of a lesion in the left transitional zone. T2 hypointense ill-defined signal with correlating ADC B2000. dark signal correlated with diffuse PSMA PET, demonstrating marked increased metabolic uptake. And so while a single lesion was prospectively described on the MRI, 4 discrete lesions were retrospectively present on the MRI in correlation with the PSMA PET. And these lesions varied in metabolic uptake. And here's another look at those 4 lesions, 3 intensely, 1 less intense. So the key story here is that we have to correlate MRI and PSMA findings, and review the MRI retrospectively for subtle or obscured lesions. So this is a 78-year-old with an abnormal PSA, 9.4 nanograms per cc. Let's look at this patient's MRI. DWI demonstrates abnormal DWI restricted signal throughout the entire peripheral zone. And similarly, we see it on EADC, but it's a little bit inhomogeneous, a little bit patchy. When we look at the T2 axial images, we see that it's really markedly abnormal T2 confluent on the right, less confluent on the left. When we look at the DCE images, we see that the left side is enhancing intensely, but the right side is not showing any enhancement. One of the things that we know about prostate MRI, we can see discordant DCE and T2 weighted imaging as lower grade tumors may enhance greater than higher grade tumors. Let's look at this patient's prostate MRI. So we see that there's an area of clear abnormal uptake on the patient's right that correlates with the area that was not enhancing. Okay, so this is intensely PSMA metabolic. And when we biopsy this patient, we find the following. On the right, the patient has a Gleason grade of 4+3, grade group 3. But on the left, correlating with that area of enhancement, that area that had less restricted diffusion, that's grade group 3. So this is a good example of a case that shows you how higher grade tumor may have less enhancement, but still have high metabolic uptake. Lesser grade tumor may have lesser enhancement, but lower uptake. Let's look at our next case. Low PSMA, high grade PSA. 64-year-old with abnormal digital rectal exam, family history of prostate cancer, and firm right apical nodule. PSA was only 2.27. Prostate MRI demonstrates a clear, confluent, bulky lesion within the right peripheral zone that extends within the extracapsular space. This lesion not only does that, but it invades and infiltrates the patient's seminal vesicle. Sagittal B1400 DWI demonstrates infiltration of the tumor within the seminal vesicle. Let's take a look at the patient's DCE. We see that there's clear abnormal marked enhancement throughout the right peripheral zone, extending within the intracapsular region, and also abnormal infiltration extending within the seminal vesicle. Let's look at this patient's PSMA PET. Whole body MIP imaging demonstrates something pretty striking. The absence of significant uptake within bulky neoplastic disease, and similarly the absence of any other uptake that we see that looks metastatic. So we see physiologic uptake within lacrimal glands, physiologic uptake within the kidneys, physiologic uptake within the liver and spleen and bowel, but no uptake suggestive of bony metastatic disease or nodal disease. Let's look at this patient's PSMA PET. So in the same area that correlates with the patient's high-grade volume of disease, we see very little uptake. In fact, it's clearly less than what we see in normal physiologic prostate. Putting an SUV, 3.21, but clearly less than that. And this correlates unquestionably with the area of abnormal T2 axial, abnormal signal on DWI and on T2 weighted imaging, and in an area that demonstrated extracapsular extension. So this is a lesion that had marked hypometabolism with large volume high-grade tumor with ECE, including invasion of the right seminal vesicle, but low level uptake within benign prostate tissue within the left prostate. So maybe there in this case, prostate MRI may be of lower yield for identification of extraprostatic disease, and therefore we may have to consider other metabolic imaging probes such as FDG PET. So let's talk a little bit about low PSMA uptake prostate cancer. Clinically significant prostate cancers may lack an intense PSMA expression. Within the subpopulation of patients without strong PSMA expression include men with neuroendocrine histology and advanced castrate resistance. Prostate cancer genomic and phenotypic heterogeneity is an additional predictor. Infiltrative rather than expansive growth pattern tumors may demonstrate little or no PSMA uptake, such as is typical for acinar tumors. So there are subtypes of prostate cancer that are known to show low PSMA uptake and something to be very wary of them. So, the conclusion, MRI and PSMA together is stronger than either alone. Integration of MRI and PSMA improves accuracy. Reader confidence supports better clinical guidance. These are complementary tools. MRI is helpful for local anatomy, tumor size, capsular and seminal vesicle invasion. PSMA PET allows for molecular sensitivity, nodal, osseous, and visceral staging. Conspicuity varies. Some lesions are MRI dominant, others are PSMA predominant, and many are concordant. Be aware of the concepts of tumoral heterogeneity. Intratumoral heterogeneity may show variable PSMA expression or enhancement within a single lesion, and mixed contiguity on PET versus MRI. Intertumoral heterogeneity is a concept where different lesions in the same patient may show different biologies and imaging patterns. Not all prostate cancers are PSMA avid. Consider FDG PET for non-PSMA avid tumors, and understand that we'll always interpret these images within the clinical context of the patient and correlate these cases with prior imaging PSMA kinetics. Thanks for your attention, and look forward to meeting you again in our next case series.